السلام عليكم ورحمة الله. أنا اسمي دكتور سمير نعيم أسعد، أستاذ في قسم أمراض الباطنة. My name is Professor Samir Naim Assaad. I am a professor in the Department of Internal Medicine, the unit of endocrinology, and the task today is to go through parathyroid disorders. And the learning objectives of this presentation is to explain about the calcium hemostasis. Number two is to recognize causes of hypercalcemia and hypocalcemia. Thirdly is to identify clinical manifestations of hyperparathyroidism and hypoparathyroidism. Fourthly is to illustrate the diagnostic approach to hyperpara and hypoparathyroidism. And fourthly, to describe the therapeutic steps for hyperparathyroidism and hypoparathyroidism. And let me recall some anatomical information that this is the thyroid glands on the posterior aspect, posterior medial aspect of the thyroid lobes. This is the thyroid gland, and on the posterior aspects of the thyroid glands there are 4 parathyroid glands. They are not anterior, they are on the posterior aspects, 4 parathyroid glands. Sometimes as an anatomical aberration we've got some extra or aberrant parathyroid gland, and usually they are below the isthmus of the thyroid. They can reach down to the great vessels of the heart. And as a point of history, the parathyroid glands were first discovered in Indian rhinoceros by Richard Owens. This is a British scientist in 1850. And but actually speaking, the gland was discovered in human by a medical student from Sweden, Victor Sandström. And to record the physiology of the calcium hemostasis, this is, as you see, the parathyroid cell, and it secretes a parathormone, circulates in the body to act on the tissues by binding to a surface receptors called the PTH receptors. It acts on the renal tubule to stimulate the calcium excretion in the urine, to inhibit the calcium excretion in urine, and to stimulate the phosphorus excretion. So by this effect, by retaining calcium in the blood, it increases serum calcium and it leads to phosphorus loss. So it retains calcium from the urine and it stimulates the excretion of phosphorus. While in the bone, it stimulates the lysis of the bone, and the calcium will move from the bone to the blood. Thirdly, it acts indirectly on the gut, and what I mean by indirectly is that it activates, as I will show you in the next slide, it activates the vitamin D. And the vitamin D will lead to a stimulation of the absorption of calcium from the gut. So by these 3 means, by retaining calcium in the urine, from the urine, by stimulating the lysis of the bone and stimulating absorption of calcium from the gut, the PTH will raise the serum calcium. And there is, as in endocrinology, there is a feedback. So we got a feedback on the calcium, receptors on the parathyroid cells, and if the calcium will go up, the PTH will go down. This is a negative feedback. And this will show you the activation of vitamin D. This is the kidney. Vitamin D, as you recall, it can be secreted or synthesized from the skin and also from food. It's activated in the liver in the 25 position. It goes to the kidney to be activated in the 125 position to have the active vitamin D. The active vitamin D has got a negative feedback on the parathyroid cells. So if the vitamin D is high, the PTH will go down and reverse, and this is expected. There is another important hormone called FGF23, fibroblast growth factor 23. It's secreted from the bone cells, the osteocytes, and actually it inhibits the activation of vitamin D. So it's doing the reverse of the PTH. And this is calcium hemostasis. This is the normal serum calcium. Remember, it's 8.5 to 10.5 milligram per deciliter. If the calcium goes down, we got stimulation of the PTH to release the calcium from the bone, and by stimulating the osteoclast and inhibiting the osteoblast, it enhances, as I mentioned, the reabsorption of calcium in the renal tubules And thirdly, stimulate the calcitriol activation by the kidneys to enhance calcium and phosphorus absorption from the gut. And it will raise the serum calcium and so on. So if the serum calcium is high, the reverse, the PTH will go down, and this is expected. So high PTH will lead to high calcium, will lead to decrease in the PTH. And let's go to the first part, is on speaking about the hyperparathyroid stage. So when we speak about parathyroid abnormality, we've got hyperpara or hypopara. As regards the causes of hyperpara, we've got three main causes. The most common is sporadic, primary hyperpara. And what I mean by primary hyperpara is that the abnormality, it is in the parathyroid gland, as I will show you. So the abnormal, but in one or more of the parathyroid gland, it secretes more PTH. Another entity is familial primary as well. Is like the primary hyperpara, but it's familial, maybe a part of a neoplastic syndrome called multiple endocrine neoplasia syndrome. We've got two types, type 1 and type 2. Type 1, it includes parathyroid adenoma, pituitary adenoma, and adenoma of the endocrine part of the pancreas. The men type 2, there is also parathyroid hyperparathyroidism, in addition to pheochromocytoma from the adrenal medulla and to medullary thyroid carcinoma. Secondary hyperpara is when the problem is in the calcium. When the calcium is low, it will lead to secondary increase in the PTH. Thirdly is the tertiary hyperpara, which I'll be speaking, inshallah, in the next few slides. As regards the primary hyperpara, the usually sporadic part, and it is usually due, most of the cases, is single adenoma. Sometimes can be to hyperplasia of the four glands or multiple adenoma, very rarely carcinoma, as you see. It's very, very, very rare. The clinical presentation of primary hyperpara, or if you want to mention the complication of primary hyperpara, let me explain to you that more than 50% of patients with the sporadic primary hyperpara, they develop accidentally. So they do not have any symptom or signs. But sometimes they can present with skeletal manifestations. This is less than 5% of the cases, and it can affect the bone in the form of osteitis fibrosa cystic, as the name implies. Due to lysis of the bone, there is cystic areas. They are not filled with air, or it is filled with fibrous tissue and granulomas. That's called osteitis fibrosa cystica. And this will appear as brown tumors because they are tumorous, and with bone cysts on the X-ray. I will show you the slides. Also, there are lytic lesions in the skull. It gives you an appearance of salt and pepper. I will show you the radiographs of our patients. Resorption, particularly in the subperiosteal part of the phalanges. Distal resorption of the clavicle, the terminal or the lateral third of the clavicle is eaten. And lastly, but not least, is the affection of the teeth and loss of lamina dura around the teeth, leading to early loss of teeth. And when we speak about premature loss of teeth, we have to think about two main diseases: diabetes mellitus and primary hyperpara. And this is the middle phalanx, and you can see there are multiple lytic lesions in the subperiosteal. This is pathognomonic for primary hyperpara. This is one of our patients with, this is the clavicle, this is the acromion, the humerus. The terminal part or the lateral part is completely lost. And this is a bone cyst or brown tumor, because in the cut section, the pathology, it appears brown. It's full of giant cells. And this is called the brown tumors. In the skull, you can see the skull should be whitish, but in this patient with primary hyperpara, there are multiple lytic lesions, small lytic lesions, and this gives the appearance of salt. The background is white and peppered with dots of black spots. And this features the multiple lytic lesion in the skull. Also, it does appear in multiple myeloma and secondaries. So primary hyperpara secondary or metastasis in the bone, and thirdly, in patient with myeloma. And this is the bone scan in patient with primary hyperpara. There are multiple hot spots in the bone isotope bone scans, and this also is important feature of primary hyperpara, but also it does occur in skeletal metastasis and also in multiple myeloma. So remember, this is not only primary hyperpara. So when you get a picture of that, you should put the differential diagnosis of primary hyperpara by doing the serum calcium and PTH, and secondly, to rule out metastasis and multiple myeloma. The other complication of presentation which occurs in 20% of the renal complication as expected. As I told you, the PTH will stimulate the reabsorption of calcium from the renal tubules, and this will give you sometimes stones or calcification in the renal medulla, leading to renal failure. So remember, one of the causes of renal failure is primary hyperpara. The neuropsychiatric changes are not specific in the form bone aches, weakness of the muscles, and fatigue. Gastrointestinal affection in the form of peptic ulcer and pancreatitis. Cardiovascular affection in primary hyperpara is in the form of, remember, of hypertension. So one of the causes of endocrine hypertension, it does include primary hyperpara. Please remember that. Primary hyperpara as a cause of hypertension, even without renal insufficiency. Once you suspect clinically if primary hyperpara, the diagnostic biochemical features include the following: high or normal serum calcium, low or normal phosphate, and inappropriately normal or increased PTH, and increased total alkaline phosphatase. These are the important features. What I mean by high normal or low normal is that sometimes the patient, you can get the calcium of 10.4. This is the high normal. It's not abnormal. And the PTH to the low side. You don't have to recall the phosphate is normally is 2.5 to 4.5, and you get a patient with 2.6 on the low side. Well, the PTH is on the high side, and the normal of PTH, you don't have to recall that, is 10 to 70 picogram per ml, and you can get the patient with 69. So calcium to the high side and phosphorus to the low side and PTH to the high side, this is features of early primary hyperpara, and usually this patient are asymptomatic. And the alkaline phosphatase is also increased in patients with primary hyperpara. Once you have diagnosed primary hyperpara, you have to think about the localizing the lesion, because I told you that 85% of patients with primary hyperpara, the sporadic part, they do have a single adenoma. And the most sensitive way to detect it is by using neck ultrasound, doing plus or minus fine needle aspiration. And this is the ultrasound, this is longitudinal scan of the thyroid lobe, this is thyroid lobe, strap muscles anteriorly and covered by the sternocleidomastoid. On the posterior aspect of the thyroid lobe, there is oval hypoechoic lesion, which is a parathyroid adenoma. Another way to localize it by doing isotope scan, and here we use the parathyroid technetium system scan. And once you inject the technetium system, it is taken by both thyroid and parathyroid. But if you wait after 1 or 2 hours, it is washed up from the thyroid gland and the parathyroid gland normally. But if there is a parathyroid adenoma, I will show you the picture, it will be retained by the parathyroid adenoma. And this, the technetium system scan, and this is the patient with left upper parathyroid adenoma. And you can see these are the salivary glands that are taken normally by the technetium. And early on, both the thyroid and the parathyroid are black, but if you wait for 2 hours, it is washed from both glands. But if there is a parathyroid adenoma, it shows as a black or dark spot. And this technetium scan is useful also for ectopic or aberrant parathyroid. And this gentleman, this picture was taken after 10 minutes. That's why the thyroid tissue is normally shown, and there is a parathyroid adenoma near the heart. And this is quite uncommon. The third way is by doing MRI on the neck, and the most recent is by doing the 4D dynamic CT. 4D dynamic CT in our experience is very useful. That's to localize the parathyroid adenoma. But sometimes all this imaging does not show the adenoma. And as you usually say, that the best way to diagnose is to localize a good surgeon, because in these cases the surgeon will do the operation, will localize the parathyroid adenoma and remove. The differential diagnosis of hypercalcemia, apart from primary hyperpara, we've got malignancy anywhere. Malignancy anywhere, even without sending metastasis to the bone, it can lead to hyperpara, and this is by secreting what we call the parathyroid-related peptide, like malignancy in the ovaries or the breast or the gut, and you can get hypercalcemia without parathyroid adenoma. Other causes of hypercalcemia, we've got sarcoidosis, hyperthyroidism, pheochromocytoma, Addison disease, the intake of thiazide, because thiazide will retain calcium in the urine, excess vitamin D, and of course immobilization. This is the hypercalcemia malignancy. This is the different tissues, as I told you: lung, breast, kidneys, ovaries, gut, or lymphoma, multiple myeloma. And this tumor secretes the PTH peptide. It will lead to high calcium, low phosphorus, but normal PTH. Because in primary hyperpara, we've got high calcium, low phosphorus, but the PTH is high. While in patient with hypercalcemia of malignancy, the calcium is high, phosphorus is low, and the PTH is normal. And for parathyroid adenoma, of course, you have to remove it. And the indication of parathyroidectomy is patient with parathyroid adenoma with symptoms, or even in patient with mild symptoms and asymptomatic. Sometimes we have to do the operation. When to do the operation in patient with mild or asymptomatic primary hyperpara? You do it when the calcium exceeds 1 milligram above the normal, or if the creatinine clearance is low, or if the bone density is low. You don't have to record these figures as a medical students, and if the patient is young, below 50 years. So if you've got one of these items, despite that the patient is completely asymptomatic, you have to remove the localized parathyroid adenoma. And in most of the cases, the surgeon, they remove it by what we call the minimal invasive surgery, by doing a small scar. Sometimes in some centers it's not available. We don't do it here in Alexandria. What we call the parathyroid mini preoperative. And this is the mini invasive. This is the classic, and this is the mini invasive video assisted, because it's the scar is very small. And this is the technician scan, preoperative. If you inject, this is the parathyroid adenoma, right lower parathyroid adenoma, and if you inject the systemibi, it will show as a hot spot. This is preoperative while the patient is on the operating table, and if you remove it, the surgery will be successful. Some surgeons, they do what we call the PTH while the patient is still on the operating theater, and they measure the PTH 10 minutes after excision of this adenoma to be dead sure that there are no other adenoma in the other three or hyperplasia. And if you get a drop of serum PTH more than 50% of the basal, I mean the pre-op, this after 10 minutes, this means that the surgery was successful. And this is one of our patients. This is the fibula. There is a lytic lesion, as I told you, the bone cyst or a brown tumor. And this, after 2 years after surgery, there is complete healing by the serum calcium. Another patient, this is the radius, and this is the ulna, and there is a lytic lesion. And after surgery, by 1 or 2 years, there is complete healing. So in this patient with multiple lytic problem, once we remove the parathyroid adenoma, the calcium will move back from the blood to the bone. Remember, move back from the blood to the bone. So it can lead to hypocalcemia and what we call the hungry bone syndrome. Hungry bone syndrome means that after removal of the parathyroid adenoma, successful removal, the calcium will move back from the bone to from the blood to the bone to heal the bone. and this will lead to hypocalcemia. This hypocalcemia is associated with a little bit elevation or normal PTH and associated with low phosphorus. While on the other hand, after operation, as a complication sometimes when the surgeon will manipulate the 4 glands, you can get post-operative hypopara. In post-operative hypopara, you get also low serum calcium. But in these cases, the PTH will be very low and the phosphorus high. So remember, low calcium, high phosphorus, and low PTH, this is post-operative hypopara, while low calcium, normal or high normal, little bit elevated, or PTH, and low phosphorus, this means hungry bone syndrome. If the patient is asymptomatic, I told you, and not indicated for surgery, sometimes you do medical treatment of overhydration, avoid thiazide to avoid the retention of calcium, give the normal intake of calcium. In post-immunobasal, even sometimes hormonal therapy or by using raloxifene, selective estrogen receptor modulator to avoid worsening of the bone loss, bisphosphonate to inhibit the osteoclast, and sometimes we give agent called calcium mimetics. These agents, they act as calcium, but they are not calcium. They have a negative feedback on the PTH, so they reduce the PTH, like the Cinecalcet. Sometimes we give vitamin D analogs, not the original vitamin D, because if you give vitamin D, it will inhibit the PTH, but it will raise the calcium. But in this case, you give what we call non-calcemic vitamin D analogs, like the paricalcitol, and this will have a negative feedback, as I told you earlier, on the PTH cells without raising the serum calcium. And this is the effect of Cinecalcet post giving it, this is failed parathyroidectomy. If you give the drug, there is lowering of the PTH. So this is primary hyperpara, and again primary hyperpara, the PTH is high, calcium is high, phosphorus is low, remember that. But you've got another type of hyperpara called secondary hyperpara, and this is due to low calcium. And if the calcium is low, as I told you earlier, the PTH should increase. And you can get low calcium due to vitamin D deficiency, and in these cases the PTH will be high, calcium is low, and the phosphorus is low, remember. Sometimes you get low calcium due to chronic kidney disease. Remember, the kidney is important for activation of vitamin D. If you don't have a good kidney, you don't have activation of vitamin D. So calcium will be low, and as a feedback, the PTH will increase. But in these cases, the phosphorus is high, because the kidney is not able to excrete phosphorus. So in chronic kidney disease leading to secondary hyperpara, the calcium is low, phosphorus is high, PTH is high. While in vitamin D deficiency, calcium is low, PTH is high, while the phosphorus is low. So sometimes in patients with chronic kidney disease, especially with end-stage renal disease on renal dialysis or after renal transplantation, apart from hyperplasia of the 4 glands, one or more of the glands, they develop what we call autonomous adenoma, and this will get a very high elevation of PTH. This will raise the serum calcium. And like this patient, they have got a specific appearance of the skull, so fluffy, the skull, you don't see the outer or inner table. And in the tertiary, of course, the phosphorus is high because of renal failure, the PTH is high, and the calcium is high. So remember, high calcium, high PTH, high phosphorus, this is tertiary hyperpara. The second part of the presentation is on the other side, on hypoparathyroidism. And hypoparathyroidism is much less common than primary hyperpara. Remember, the instances of primary hyperpara in different series varies from 1% to 1/1000. So they are not uncommon, the primary hyperpara. While the hypopara is less common. And hypopara is expected due to a lack of secretion of PTH, the calcium will be low. And here we have to recognize the different causes of hypocalcemia. And of course, hypocalcemia can be due to hypopara, and in this case the calcium will be low and the PTH will be low. And the most common causes are surgery, post-operative, whether post-thyroidectomy or after parathyroid surgery. And the other cause is autoimmune, polyglandular failure syndrome. In the polyglandular failure syndrome, there are multiple failure of the different endocrine problems. And please do not confuse it with the multiple endocrine neoplasia, as I mentioned. Multiple endocrine neoplasia, multiple endocrine tumor, type 1 and type 2. But polyglandular failure syndrome, also we do have type 1, type 2. So please don't be confused. In type 1, you get mucocutaneous candidiasis, Addison disease, and hypopara. While in type 2, you've got Addison disease is common to both types, autoimmune thyroid, whether hyperthyroidism gravis or hypothyroidism, and type 1 diabetes. Rarely you get agenesis of the parathyroid gland. Sometimes we got hypocalcemia with high PTH, and as you remember, when the calcium is low, it will lead to increase in the PTH. The most common is vitamin D deficiency due to malabsorption or liver disease or chronic liver disease or due to vitamin D deficiency. But you have to remember that there is an entity called PTH resistance. PTH resistance means that the PTH is secreted normally, but it does not act on the PTH. And the acquired type is due to magnesium deficiency, but there is a hereditary type called pseudo-hypopara. So in the pseudo-hypopara, there is low calcium, like hypopara, but actually the PTH will be high. So remember, in pseudo-hypopara, the calcium will be low because the PTH is not acting while the PTH cells are secreting, so you get high PTH. This is. Other causes of hypocalcemia can be due to acute pancreatitis, tumor lysis syndrome, massive blood transfusion, and endotoxemia by the Staph aureus, what we call the toxic shock syndrome. The causes of magnesium deficiency can be due to endocrine causes like hyperthyroidism or diabetic ketoacidosis, malabsorption, or total parenteral nutrition if you don't give magnesium. Intake of diuretics, remember, the intake of diuretics, it will lead to muscle spasm in the patient, not due to hypokalemia. It is due to magnesium deficiency. So what you have to do in patient on diuretic-induced muscle spasm is to give them magnesium. Osmotic diuretic, of course, and the garamycin or the gentamicin antibiotic, the aminoglycoside also can lead to magnesium deficiency. And this is the polyglandular failure syndrome. Recall, you have to remember there are type 1 and type 2, and this is polyglandular failure syndrome. Don't mix it with multiple endocrine neoplasia. Multiple endocrine neoplasia type 1, remember, pituitary tumor, parathyroid tumors, and endocrine pancreatic tumor. Type 2 multiple endocrine neoplasia, you got again parathyroid adenoma, medullary carcinoma of thyroid, and pheochromocytoma. So don't mix the polyglandular failure syndrome with multiple endocrine neoplasia. The clinical features of hypocalcemia, of course, you remember from the physiology that you've got the typical tetany. You got contraction in the wrist and contraction in the metacarpophalangeal joint with extension in the interphalangeal joint, the typical tetany. And there are other features apart from tetany. You can get bronchospasm. So a patient with hypocalcemia, they can mix with bronchial asthma, laryngospasm, leading sometimes to stridor, paresthesias, particularly around the mouth and in the lips and tongue. And remember, numbness in the tongue, it can be due to hypoglycemia or due to hypocalcemia. Remember that. Sometimes the hypocalcemia will lead to generalized fits, and we've got actually, unfortunately, many patients with primary hyperpara diagnosed as generalized fits, and they have been given anti-epileptic drugs for years. So remember, if you got a young patient with seizures or fits, before labeling him as epileptic patient, just measure the serum calcium. We've got two interesting signs. I will show the photographs, the Zvostek sign and the Trousseau sign. But the most dramatic, sometimes fatal feature of hypocalcemia is prolongation of the QT interval, leading to sometimes to cardiac arrest due to ventricular fibrillation. And this is very important because hypocalcemia presenting with tetany, of course you will see the tetany will give calcium. But remember that this will not kill the patient unless you neglect it. But the QT interval with VF, it can kill the patient in a few minutes. And these are the Trousseau sign. You bring the sphygmanometer, you inflate it above the systolic for a few minutes, and you can get the typical tetany in the hand. And sometimes you get also a pedal spasm. You can get pedal spasm, not by the Trousseau, but pedal spasm due to hypocalcemia. And this Trousseau sign is positive when the serum calcium is borderline low, because if the serum calcium is less than 7, it will give to manifest tetany. But latent tetany induced by the sphygmanometer means that the calcium is of course, if it is very low, it will be positive, but also mild lowering, it also be positive. The typical Schwarzschild sign, you tap on the facial nerve after its exit from the stylomastoid foramen, just anterior to the lower part of the ear. Normally you don't get anything, but if you tap on this, you get contraction of the orbicularis oris and orbicularis oculi, and this is typical for hypocalcemia. Hypocalcemia can lead to stridor, as I told you, and it can lead to exaggerated reflexes. Hypopara, these are the manifestation of acute hypopara or acute manifestation. But chronic manifestation of hypopara, it includes calcification occurring particularly in the brain, in the basal ganglia, and it can lead to extrapyramidal neurological manifestation. And we don't know why there is a predilection for the deposition of calcium in this particular area of the brain. You can get early or premature subcapsular cataracts. You can get abnormality in the cornea and abnormality in the teeth. This is chronic hypopara. And this is a CT of the patient. This is basal ganglia calcified. They appear white as the bone. So this calcification. And this is one of our patients. This is quite hazy. These are the lateral ventricles. They appear black, CSF black on CT. This is the skull, white. And these are the basal ganglia. Here there is calcification in the basal ganglia. And this is the same patient, but coronal view. And these are the basal ganglia. And inside the basal ganglia, there is crossing of the internal capsule. This is the internal capsule. The diagnosis of hypopara, of course, you will get low PTH hormone. The calcium will be low, and the phosphorus will be high. The reverse of primary hyperpara. Primary hyperpara, the calcium is high, phosphorus is low, and the PTH is high. But in patient with hypopara, whatever is the etiology, the calcium will be low, the phosphate will be high, and the PTH will be low. And the alkaline phosphatase will be normal, not like primary hyperparathyroidism. In patients who resistant to PTH, the hereditary syndrome, what we call the pseudo-hypopara, they have got, as I told you, low calcium, high PTH, but also high phosphorus. So low calcium, high phosphorus, and high PTH. And this will give you the same features as you remember of secondary hyperpara due to chronic kidney disease. Chronic kidney disease have got low calcium, high phosphorus, and high PTH. But of course, you'll be measuring the serum creatinine, so you will recognize that this is secondary hyperpara due to chronic disease, not due to pseudo-hypopara. Patients with pseudo-hypopara, they can have dysmorphic features, like one of our patients, they are short in stature, rounded face, submentality, and with premature cataract. And the typical features, they have got the fourth and fifth metacarpals. They are short. That's why the fingers are short with absent knuckles, particularly the fifth and the fourth. And you can see this is the X-ray. The fifth and the fourth metacarpals are very short, so you don't see the knuckles in the hand. So normally we have 4 knuckles, but in this patient, the fifth and fourth knuckles, they do not appear. At the end, treatment of hypoparathyroidism is to correct the serum calcium. And in emergency, you have to give the serum calcium IV. You give 1 ampoule or 2 ampoules of calcium gluconate infusion. You put it in glucose, and you give it as intravenous drip. While if it is not an emergency, you give it oral. You can give up to 6 grams in severe cases. And you give vitamin D, because remember, in PTH deficiency, there is no activation of vitamin D. If you want to increase the calcium, you give high dose of the vitamin D3 or D2, and high dose, 25,000, even 100,000 per day. This is to overcome the lack of activation. So usually you give 1,000, 2,000 units per day, patient with vitamin D deficiency, but in these cases you give very high dose. Or you can give the active vitamin D, the 125 vitamin D, called calcitriol. And sometimes we give small dose of thiazide, because thiazide, as I told you earlier, it stimulates the reabsorption of calcium from the renal tubule. So it will raise the serum calcium and lower the calcium in the urine. Because this is important, because in long-standing hypopara, once we give calcium and vitamin D, you get as a complication urinary calcium stones. So by giving thiazide, you can protect this patient from having renal stones in patients with prolonged hypopara given calcium and vitamin D. Lastly is the most recent treatment for the hypopara is by giving the PTH replacement. The form of injection is not available in Egypt for treatment of hypopara, and even abroad it is in the guidelines. They don't use it as first line. They use it only for resistant cases if the patient is not responding to the usual classic treatment, which is the form of calcium and vitamin D. So at the end, I'll just recapitulate by saying that the primary hyperpara are the most common causes of hypercalcemia, followed by malignancy. And you remember, you have to recall that in primary hyperpara, the calcium is high, the PTH is high, and phosphorus is low. Another cause of hyperparathyroidism is secondary, due to low calcium. And you can get low calcium due to vitamin D deficiency. In these cases, the calcium will be low, PTH high, and the phosphorus will be low as well. While in patients with vitamin D deficiency due to chronic kidney disease leading to secondary hyperpara, in these cases the calcium will be low, I mean sometimes low normal, and PTH is high, but the phosphorus will be high. In neglected end-stage renal disease, on dialysis, you can get sometimes marked increase in the PTH leading to autonomous secretion of the PTH from the not only hyperplastic gland but adenoma gland, one or more of the gland, but they develop adenoma leading to a marked increase in the calcium with increased phosphorus. So in tertiary hyperpara, you get high PTH, high phosphorus, and high calcium. The less common parathyroid disorders are the hypopara, and hypopara is an important cause for hypocalcemia, but there are other causes of hypocalcemia with increased PTH, as I told you, in vitamin D deficiency, in magnesium deficiency, or the rare pseudo-hypoparathyroidism. And the most common cause of hypopara is surgery followed by the autoimmune affection, the polyglandular failure syndrome, and don't mix it up with the multiple endocrine neoplasia, because we've got type 1 and type 2 in both. And the features of the hypopara, I've got low PTH, low calcium, and the phosphorus will be high. Remember, there are features of hypoparathyroidism. And thank you very much for your attention. Thank you.